Hey, Jill,
Good morning.
you want to cut recording off?
Uh,
Because it was recording and I was on.
oh, please ask the host to give you permission to record. It's already recording.
Yeah, it automatically started recording.
How do I turn that
Did
off?
you click into the link on the calendar or did you go in through
Mm,
Zoom? Go in through Zoom for some
Okay.
reason. Uh, I don't know. When I click on the calendar and I made it, it doesn't allow me
Doesn't
to
let
do the
you.
same things.
All right, I'll be.
Right. Yeah, it's
All right. Good morning, everyone. I am Dr. Jewel Yoder. I serve as the co-director for this program for Goshen College, and I have my colleague, Dr. Melody Cash, who is the co-director of the DNP program from Eastern Mennonite University, and the entire kind of DNP faculty group. We welcome you all to Catherine DeSantis's defense of her Doctor of Nursing Practice project proposal here today. So thank you for joining us for Catherine's defense of her DNP project proposal. Before I introduce Dr. Melody Cash, who is Catherine's lead faculty on her project, I just wanted to make some announcements and help orient everybody to how the day will go, as we have some people that are new to this process. So as you can tell, the session is being recorded. We do ask that all the guests keep your sound muted during this event. We would love you to have your video on so that Catherine gets the sense that there's an audience that she is giving her presentation to. So if you're able to do so, please keep your video camera on. You will want to see the speaker view is typically the best way to see it. So to do that, you just kind of go up to the top of your Zoom screen. On the far right of the top bar, you see an option for either gallery or speaker view, and that will help kind of enlarge Catherine, and we kind of all become little boxes off to the side a little bit. This presentation is scheduled to take 30 minutes. So Catherine, you'll have 30 minutes to give your presentation to us here this morning. We have found over time that it's a little bit tricky to figure out how to do like a warning signal at 5 minutes and at 1 minute. And so I will probably end up putting something in the chat, which is not the most ideal. As you get to 1 minute, Catherine, if you're at that point, I will just kind of quickly interrupt and say, okay, about a minute left here, Catherine. After Catherine has given us her presentation, that is your time as an audience to really engage with what she has shared. You can feel free to ask her questions just by unmuting yourself and raising, and asking the question, or you can put them in the chat feature, and I'm happy to read them off to her. We'll let that Q&A session go until kind of the questions have died down a little bit. And after that, all of our audience members will be dismissed, except for her lead faculty, which is Melody Cash, and then myself and Dr. Ruth Stolzfus are serving as her project
approval.
committee Approval, thank you. That was the word I was looking for. Project Approval Committee members. And we will stay on with Catherine and continue some conversation with her. So at this point, it is my pleasure to turn this over to my colleague, Dr. Melody Cash, who will introduce Catherine and her team and project.
Yeah, and it is my pleasure to introduce Catherine and her team. So on her team is Amanda Aldano, and Tammy Ronaldo, who was unable to be here, is her student peer. So Catherine Dos Santos is a family nurse practitioner, and she is here to defend her project proposal, Enhancing Menopause Management in Primary Care, Implementation of a Menopause Education and Treatment Toolkit. So, Catherine, it's all yours.
Good morning. Well, this is a fun presentation to learn about menopause and what we can do in family practice. So my project is centered around implementation of a menopause education treatment toolkit that I am going to create. So as a introduction, one moment. Okay. Menopause affects nearly all women. The definition of menopause is defined as the one day that a woman between the age, usually generally between the age of 40 and 60, has 12 months of amenorrhea, or her periods have ceased in the natural sense of menopause. This can occur anywhere between the age of 40 and 60. Average age is 51, and there are many under-recognized symptoms and treatment in primary care. The symptoms of menopause include hot flashes, sleep disturbances. Genitourinary symptoms of menopause include multiple vaginal symptoms, including dryness and decreased libido, mood changes. Recently, we've discovered 70 symptoms that are attributed to menopause. In the past, women were called whiny women when they would come into primary care. This is a fact. You can ask any provider, any doctor, any nurse practitioner, physician's assistant that has worked in primary care and trained in the last 20 years. And the presentation of the woman would be multiple complaints. And the definition often was WW, whiny woman. Unfortunately, there are multiple knowledge gaps in provider confidence, knowledge, and treatment. This is important for this project. It's the confidence level, their knowledge, and their treatment recommendations. In women visits, it needs to be recognized also that there's not much time for all of the things that we as primary care providers must discuss. And what menopause is not often one of them. And therefore, this project also centers around recognizing and helping the patient recognize menopause symptoms as well. So in a historical context, in the 1960s, menopause became known more in something called the feminist movement. And there was a book written called Feminine Forever. And in that book, the author defined menopause as a deficiency of estrogen. That's where HRT came from. Hormone replacement therapy is HRT. So they defined it as a disease of every woman in their 40 to 60 years. And that's the time when estrogen started being used in medicine. And the estrogen that they had at that time came from horses. And it was estrogen from horse urine, pregnant horse urine to be exact. And that was the only treatment at that point. So from let me switch my slide here. Sorry. So from 1960s to 1980s, they used this, and there was no opposing estrogen for any woman with a uterus or without a uterus. Therefore, endometrial cancer became a role in medicine, and they blamed the estrogen for this. And then there was controversy during that time. So then again, women were, whether they were treated or not, was was a controversy and they stopped using it. And then further research showed that combining estrogen with progesterone, if you had an intact uterus at that time, reduced the risk of endometrial cancer. So they were using it, but it was still controversial. So this is way back in the 1960s, 70s, and 80s. Then in the mid 1980s, the FDA approved an estrogen therapy for hot flashes and osteoporosis prevention. And that became used for those two symptoms of menopause. But it was still controversial, and it became continuous rise in controversy. In 1998, there was a study that was to date the largest study that has ever been done for menopausal women. And the initial study was started for increased risk of coronary artery disease, and also seeing if it decreased the risk of osteoporotic fractures. And they discovered that colon cancer was decreased as well. However, and previous to this, in 1988, the American College of Physicians developed the first guidelines. That's important to understand in this timeline as well. So the first guidelines were developed in 1988 for hormone replacement therapy. There were minimal studies at this time, though, and it was marketed for chronic disease prevention in postmenopausal women. So then the WHI, the Women Health Initiative, came out, started in 1998, and was the largest study to date. And in that study, they found they gave combined therapy to women with uterus intact, and it was the conjugated equine estrogen at one dose and a progesterone that was synthetic. It was not bioidentical to humans, and we still use it today. And those were the only two options in this study. So that's very important to remember as well as we go along this timeline. Then in 2002, this study in 1998, the WHI, the most important study that I will reference throughout this presentation, is going on. And then another study in 2002 called the HERS-2, or Heart and Estrogen Progesterone Replacement Study, came out as well at the same time. And they monitored 4 years of the CEE, which is a conjugated estrogen, and progesterone. And it also increased growing controversy. When in 2002, the WHI, or the Women's Health Initiative, had an early halt. This is when they discovered increased risks of breast cancer and coronary artery disease for the women in this study, which is the largest to date, and that were receiving both estrogen and progesterone. Those that were not taking the progesterone, they did not have as much increase. However, the media got a hold of it, and the media put it out saying no longer should estrogen and progesterone be used. Women are getting breast cancer, heart disease, and it halted. It was between 2002 and the next 5 years, there was a decrease of estradiol and progesterone or any hormone replacement therapy in any woman by 84% across the world. It's also important to note that women who were of color, Hispanic, Black, they actually took longer to stop the hormone treatment for them because of access to care. So there is definitely diversity here, and a lack of continuity of care. So 84% reduction in the world. This left from 2002 to 2017 to 2018, whiny women not receiving any estrogen treatment. So what does that do? That causes us to increase research on other options that are used, that can be used. So this caused a shift in the research to focus on non-hormonal treatment. And the focus includes SSRIs, which are serotonin reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors, gabapentin, CBT, not CBD, actually, that might be a good study. CBT, cognitive behavioral therapy, and herbal remedies have all been studied, and there are some excellent choices. None of them compare to menopause treatment. I apologize about the beeping. I can't turn that off because I'm on my computer. So if you hear it, I apologize. So none matched hormone replacement therapy for whiny women, but misconceptions, fear of litigation, and inadequate provider education continued lower prescription rates. The Women's Health Health Initiative included multiple design flaws. So in 2017 to 2018, 16 years, a reanalysis was completed, and they discovered that the average woman in the study of the WHI, the largest to date, was 63. Menopause average age is 51. That was a very skewed result. And we're talking 16,000 women. Coronary artery disease was established at this age generally. So when you start hormone therapy and establish coronary artery disease, you will see an increase. We generally don't develop coronary artery disease until after menopause. Therefore, the newest studies are now recommending recognizing symptoms early. This caused distorted applicability of findings of younger women newly entering menopause. And the post WHI, post women's health clarification, due to that reanalysis, shows risks overestimated in the younger women population. And apologize here. And MHT became the new term. There is no documentation of the date that occurred. So further research that I had to dig to find when it became MHT, which is actually the newest term we use, menopausal hormone therapy, because HRT, hormone replacement therapy, treats a deficiency. We're replacing something lost, someone who has a deficiency or a disease. So around 2013, I found data that they started using the term of MHT. Both terms can be used, but MHT is preferred, menopausal hormone therapy. It was determined to be safe and effective in most women less than 60 years old within 10 years of postmenopause. And there's some newer guidelines, even in addition to that, 10 years, less than 10 years within symptom onset. A woman can develop symptoms of menopause between 7 to 9 years prior to the one day that's menopause and continue for 7 to 9 years after. These are important things to note in this study as well. So over the 16 years between, this is a very important piece of information as well. Breast cancer risk did not increase. During the time, we had 84% reduced hormone therapy through the world. They actually became stabilized or decreased. Coronary artery disease, bone fractures, and endometrial cancer either increased or unchanged over the 16 years that we had a reduced treatment algorithm. My problem statement highlights poor recognition and under-treatment in primary care. The 2002 Women's Health Initiative caused significant fear around the world for hormone therapy. And even though evidence supports, I apologize, I have to move a little part of my screen. And even though evidence has since been clarified, providers are hesitant. Menopause hormone therapy is safe and effective for many and most women, yet it's underutilized, while less effective treatments are often chosen. Gaps in practice. It's important to understand that when providers approach menopausal hormone treatment, there is a lack of structured education and resources, and there's inconsistent use of menopausal hormone therapy across primary care, as well as other entities, including gynecology, endocrinology, and osteoporotic treatment. We have a reliance on less effective options, and again, a large knowledge gap with multiple providers not understanding the current guidelines, and access to easy resources is very limited. The purpose of the project: we need to understand that implementing a menopause educational and treatment toolkit is needed. Upon research, I was only able to find 2 in the world that are current and up to date. They're very, very lengthy and extensive. We do use them in my office after I found them, and the providers that I work with were very happy about that. But it is very time consuming because it's a very complex, not disease, it's a very complex state of a woman's age between 40 and 60, and understanding the best treatment for that individual. We need to evaluate the impact on PCP, primary care provider, recognition, knowledge, and confidence. And that's what is shown to be lacking. And we are also, I would like to also create support evidence-based practice. My PICO question: my population is women between the age of 40 and 60. My intervention, I would like to create an education toolkit encompassing symptom management strategies, lifestyle modifications, and treatment options. It's compared to having a standard care with a toolkit or no toolkit. And my outcome, will it affect provider recognition of menopause symptoms, knowledge, and confidence in management? That is my hope, to increase this. And the time is over the course of the project. The time of the implementation period, I am aiming for 6 months. Provider knowledge gaps again. Residents, this is in the literature search, was found that residents and primary care providers, including nurse practitioners and physician's assistants, there's actually no report just for nurse practitioners during the course of the time of this research that specify for nurse practitioners, but they were included in 2 to 3 of the reports that I found. PCPs report discomfort in prescribing menopausal hormone treatment. The percentages are mind-opening, they're just boggling. So 10.4% of a national survey that was done for primary care providers, including all physicians, nurse practitioners, and physician's assistants, report that they assess symptoms of genitourinary symptoms of menopause. However, 75% may prescribe it. They prescribe lubricants and vaginal estrogen. However, they can't tell you they couldn't state the black box warning for the estradiol. So there's a very large knowledge gap there. So I want to give you a clinical vignette. I want you to understand what it's like in primary care when you're working with women and multiple populations. You're a primary care provider, you have a 46-year-old female, and she's here for a wellness visit. In that wellness visit, you must cover everything from dentist visits, eye doctor visits, all the way to how is she doing with her periods. During her wellness visit, she expresses that she's having vaginal dryness, reduced libido, daytime hot flashes, and issues sleeping and mood swings. She inquires what's available, and the provider recognizes there's a lack of immediate knowledge and current guidelines and defers treatment pending to a follow-up. This scenario happens every day in primary care, and it is important to have a quick and easy tool to access. Even with the resources we have now, it takes time, and sometimes it's still difficult because each patient's different and you have to make sure that it's safe for that individual. So a training and guideline awareness remains inconsistent. Menopause has been found to be a significant economic and health impact. $1.8 billion of annual productivity loss was discovered in a recent study by Mayo Clinic for menopausal women. Menopausal women often have sleep disturbances. They sometimes have mood changes, including feeling like there is research that women feel like they're bipolar, have extreme anxiety during menopause years, and this has been led to calling off, difficulty focusing, and so work productivity has decreased $1.8 billion lost. The disparities are also increased in Black and Hispanic women, and the symptoms were actually less reported and less treated in that population. So there's a need for a clinical tool. The existing guidelines, now I must recognize that when I was doing this project over 2 years, the NAMS, which is the North American Menopause Society, is now the Menopause Society, and so the names are going to change between my old research and my new research. They're the same entity, so I'm going to use NAMS because currently it's what this part of the project information was obtained from. So NAMS is North American Menopause Society. ACOG is the American College of Obstetrics and Gynecology. There are some guidelines that they're coming out with new, actually every month, but they are underused. They're hard to obtain quickly. But they are recognized and they're working on them. And we need a tool. The toolkit would simplify decisions in a busy practice. In my project, I'm using for my theoretical framework guideline, the theory of planned behavior. Sorry. The theory of planned behavior recognizes attitudes, subjective norms, and perceived behavioral control. I'm using this theory for providers. The providers are the one in this, are the people in my study that are going to be utilized, not patients. My goal is to help change attitudes and subjective norms for menopausal treatment. Using the theory of planned behavior is I'm going to change this to another picture where you can see. It explains provider behavior change and can be utilized to assist in that process of changed behavior. And there's a behavior intention of treating menopause, recognizing and feeling confident, and the attitude, subjective norms, and behavior, perceived behavior control are all utilized in the theory of planned behavior. As well as the theory of planned behavior, I'm also using conceptual framework with the IHI, and this will be the planned, do, study, act cycle. And it's important to recognize that this cycle is an iterative cycle. Therefore, I hope to do at least two evaluated rounds of the study or of the information collection, and adapt each change while we evaluate and reevaluate. This is another picture of the planned, do, study, and act cycle. I did a local needs assessment. It's important to recognize this in order to understand why the toolkit is needed in this area as well. I sent out a monkey survey, survey monkey, to 30 providers in my network. 13 answered, and 69% of them had neutral confidence. This is for primary care, and we treat women 40 to 60, and they also, only 4 of the 13 actually prescribe menopausal hormone therapy consistently, and 85% of them are interested in more education. 85% of the providers that answered my survey are interested in more education. This was experience ranged from new to people who have been in, well, the people that I sent it to, of course, this was an anonymous survey, so I don't know who answered, but there were many providers that have been in practice for 30 plus years. And it was very eye-opening. The other thing I noticed was at the end of the survey, I asked if anybody was aware of the women's health initiatives and what errors were found. Very few were aware of the errors, and almost all were interested in understanding what the new guidelines were for recommendation. 11 out of the 13 actually were very interested or somewhat interested in learning more about menopause treatment and primary care. The design of my project, I would like to do a pre and post quality improvement project, a pre-survey and a post-survey. And about confidence, knowledge, and treatment. And it will be guided by the theory of planned behavior and the PDSA cycle. It is voluntary. I'm not using patients as any studies, any participants. And before and after evaluation and recognition of menopausal symptoms and treatment knowledge and confidence will be assessed. Participants, as I said, family practice. This will be a combination of physicians and nurse practitioners. Maybe a physician assistant will be involved in using my toolkit. And it's a family practice offices. 1 to 3 offices is my goal in the Northern Indiana area. And these primary care providers must see women ages 40 to 60. Toolkit components, I would like to have a symptom checklist for the provider to utilize, possibly for the patient to complete. There's the treatment algorithm. I would like to include hormonal and non-hormonal strategies. I'm going to click on one as we move to the next slide because it has a picture. Patient handouts as well, and optional, oh, I apologize. There we go. An optional training session. And it's optional because I would like to have the training session to be on a computer, not a module that can be quickly 15 to 20 minutes, how to use the toolkit, what to expect, what to be thinking of during the time we utilize it in our daily practice. And I would like to have some hyperlinked, the Menopause Society and ACOG guidelines available in our computer system if possible. And further development would be findings from needs assessments, current recommendations, and utilize 2 existing toolkits I plan to use. The one is from Australia and one is from India. They're very extensive, as I said before, and they are very good, but there is a lot of information in them. My implementation plan, as I stated before, I'd like to have a 15 to 20-minute orientation session that's optional for each provider that will be using my toolkit. And the timeline for a session will be approximately 3 months. In month 1, I plan on completing the planning phase, finalizing the menopause toolkit, obtaining my IRB approval, coordinating implementation and logistics with the sites that I'm using. In month 2 would be my do phase, and I'd like to introduce the toolkit and the orientation. Month 3 would be the study phase. Pre and post intervention surveys will be utilized and collected, and retrospective chart audits or self-reported logs reviewed, and evaluate changes in provider confidence and symptom recognition. And in month 4 will be my ACT phase, and reviewing feedback, outcome data, targeted revisions to the toolkit, and preparing for the final project summary. After month 4, if there is time, I would like to repeat the cycle and abbreviated between month 5 and 6. I think that this stands to have some work discussion on exactly timelines that we can do together, but that is approximately what I would like my timeline to be. Data collection is going to be pre and post surveys to assess confidence and knowledge, chart audits for symptom recognition, and provider feedback. Plan on developing the focus group with the providers that are involved, if they choose to be involved in the focus group. It's important to recognize that with the PDSA and the IHI, we must have a balancing measure. The balancing measure is used in quality improvement projects to help identify and monitor unintended and negative consequences of a change that might arise in another part of the system. So I would like to use the length of time in the room using the toolkit as my balancing measure. Did it impact your time in the room? Did it cause a delay in your day? And I want to monitor and identify negative and unintended consequences of the time. It will be tracked before, during, and ideally, these visits ideally will be during their Well Women exam. This is the time that many women will actually offer these symptoms and ask for treatment. Quality analysis. This is a small study, so I don't know how much a paired T test or Wilcoxon for the surveys will work, but we may use them. And then descriptive stats for chart audits will be utilized. And again, the T-tests and the Wilcoxon surveys will be used for pre and post data to see if there is a significant difference or outliers. Quality analysis, descriptive review of provider comments. Themes include attitudes, controls, and norms, as the theory of planned behavior utilizes. Sustainability plan, I would like to embed this toolkit. If the outcome is good, I would like to embed it in the onboarding with new providers and continuing education. I plan on using laminated guides and intranet access with links for the NAMS or the Menopause Society and ACOG. And I would like to use a modular format allowing for updates, because it is continually updating. So the potential impact of my project will improve PCP confidence, guideline use, reduces disparities among all of our women population between age 40 and 60, and enhance the quality of life for women, including those 70 symptoms in those whiny women. They're not whiny women, by the way. I was using that tool. Summary and of gaps and purpose. So the gaps are under-recognized, undertreated menopausal women. And I would like to come up with a solution with a toolkit in education. Implications for nursing practice. This advances the NP role and promotes evidence-based equitable care, promotes a team approach, leadership, and increases the translation of evidence into practice, leading teams in quality improvement, promoting equitable and evidence-based care. My future directions would, as a look ahead, I thought about what would my future direction include. Since we're using Well Women exams, the future direction would be to dedicate a menopause visit. During that Well Women exam, the provider could say and does say, let's bring you back and talk about this alone and give the guideline of what all needs to be obtained, including mammogram, cholesterol, and discuss in one visit, which is a long visit in of itself, the qualifications for menopausal hormone treatment for that patient, and then expand to system-wide adaptation if possible. In my conclusion, this project addresses major women's health gaps. A toolkit equals practical, sustainable solution and advances PCP or primary care provider, nurse practitioner, physicians, PA's confidence in treatment, recognition, and knowledge. I welcome questions.
All right, Catherine, thank you very much for that presentation. It certainly gave us a lot to think about. Amanda has chimed in the chat. She says, I look forward to seeing your toolkit and the outcomes it creates. I appreciate your work sorry, now I gotta pop it open, to start a change at the provider level. I'm sure it will be positive, patient outcomes, great work. Others that now, having heard this, have questions for Catherine, we would open the floor up to questions. Don, please go ahead and unmute yourself.
Well, thank you, Catherine. I know it's been a long time coming for you to get to this point, so congratulations on that. Just a question of clarity. You said that you were going to implement the toolkit over 3 months, but in your description, you seem to you talked about month 2 implementing the toolkit, but then month 3 measuring and month 4 focusing on the ACT phase. But can I assume that months 2, 3, and 4, the toolkit would continue? In other words, is there to get 3 months of actual implementation? That wasn't real clear to me.
Yeah, I had put that 3 months and turned in my PowerPoint and didn't think I could change it. After I reviewed it, I said, "Oh, that's not really." I have the same question. So my desire is a full 6 month. Maybe it may end up being honestly 7 to 8 if in order to get all the data, because that month 1 and 2 are creating. I haven't created the toolkit yet. Correct. So I really would like to do a 3 month cycle, but what would be more ideal would be 1 month cycle 3 times. Does that make sense? So the provider implementation cycle over a month, because if I really want 3 to 4 providers that are using the tool, and in 1 month, a full-time primary care provider can see quite a bit of women in this age group, but in another month, it can be like 2. So that's where this gets difficult. The other thing is there are a lot of part-time providers. So 2 of them are part-time that are for sure implementing. 1 of them is full-time. And I believe I'm going to try to get 1 more. 2 physicians and 2 NPs actually are hopefully willing. So that's where this is going to need fine-tuned. I really want 3 full cycles because I think that's going to give me the best PDSA, and using that iterative and getting feedback and then fine-tuning and re-implementing. And by the final product, we have our attitudes changed, we have our subjective norms, and it just becomes normal behavior.
Yeah, and that's fine. As you know from IHI, that they talk about rapid cycle change and being just good enough with your change. I think as you do, especially with that irregularity of patient visits.
Yeah.
I could say, at least 3 whole months of implementing the toolkit with, as you said, iterative corrections along the way, seems very appropriate. I just want to make sure
Yeah.
that the toolkit was being implemented for a good chunk of time,
Agreed.
for a DNP student. So thank you.
Yeah, agreed. Thank you.
Hi, Catherine. Thanks for your presentation today. I have kind of a practical question. Are you rolling this work into some of the paid employment you have, or is this sort of like on your free time that you plan on doing the toolkit and your follow-up analysis? Just wondering kind of like how it will work for you.
Great question. It is my job, and I am already doing this. I have been since I started the project. So this is some of the questions I have too of, do I implement this? Because I already am, but I don't have my own toolkit. It has to be on my work because I work every day. So I'm not really sure how that works for the DNP project.
I guess what I'm asking is with that, are you seeing patients all day long, or do you have time set aside for doing your research? Is what I'm asking.
Great question. Okay, yes, I have for the last 2 years taken one day off every other week for my focus on my DNP project. So some of those days have actually failed because of work, but I plan 8 hours a week for the next 6 months for this project. I have it all scheduled out and worked out on my schedule. I am taking days off and out of work just for this. So every other week I have blocked out 8 hour, a whole day. So when I calculate the hours and 300 hours over 6 months, it's 8 hours a week.
Yeah, yeah. I'm
Thank
looking
you.
forward to seeing the results. It's an ambitious project,
I
for
know.
sure. Yeah.
It is so important, and we're already doing it. So I'm becoming like the menopausal hormone question person now. So, which is great. And women their lives are changed. It's just amazing.
Anyone else? Catherine, Ruth, and Melody and I kind of hold our questions till after, so
Okay.
there's more to come. It's just I'm kind of asking your audience here.
Yeah, I was like, Ruth, no questions?
All right. Hearing no further questions, I want to thank Don and Susan and Margaret for joining us here today. We really appreciate your time, and we will dismiss the three of you so you can sign off, and the rest of us will remain.
Thank you. Good luck, Catherine.
Thank you.
And I think we can probably stop the screen sharing, and I'm going to pause our ladies. All right. Okay. So Catherine, thank you for your presentation. Again, I know our timing gets a little bit wonky, but just as a point of order, as you come back to us at some point, you took about 33 minutes, so a little bit
Oh.
over. So you'll want to speed up a little bit more, I guess, especially because the next time you're going to have even more to be
Okay.
presenting. So
Okay.
um,
Didn't know that.
just watch that just a little bit with it. I don't know who wants to go first here with questions. If you want me just to
Well, I
jump
just
in, or
want
where do we
to
want to start? Yeah.
tag into what you just said, Jewel. So, Catherine, your historical stuff was great, but I have to say that you didn't get to the purpose until 14 minutes in.
Okay.
So
Yeah.
the first part, I mean, it was really well done. So, so it's, but yeah.
Okay.
And you could even move that up to sooner in the project, almost
Yeah.
before the history, because you give kind of a nice background. And so, yeah, a little bit with that. I think that was, I didn't time that quite, Ruth, but yeah, I was kind of like, okay.
Oh, okay.
Yeah.
Okay. I didn't realize that.
No.
Okay.
I mean, I can give you, I at about slide 4, I started, you were already presenting for 11 minutes. I had a stopwatch going, so I have from about slide 4 to the end,
Well,
some,
and you'll have this as you'll see this as a
yes.
presentation,
Oh, that's
Catherine.
right.
So we'll send it back to you. You'll have the link that you can rewatch and kind of do your own timing and critiquing of, okay, next time I'm gonna cut this out or
Okay.
speed it up. So you'll have that to
Okay.
critique. I don't know where we want to jump in. I'm gonna start with I think a concern I have about the actual implementation of sort of you saying that you have, I think you were saying to Susan, 8 hours every other week. Is that what I was hearing you say?
Out of work, and then I'll make the time on the off week. That's not, it'll have to be weekend.
Okay,
So
all right, because
she
that's, I
asked,
was like, I'm doing
yeah.
the math and I'm like, this is not 300 hours
Yeah,
worth,
no,
even if this was
no.
every week, 8 hours,
So
so.
no, I should have explained better. So
Okay,
she asked if I was going to do it during my time at work. So I have
gotcha.
scheduled off every other, and no, it has to be 8 hours a week or I won't meet the 300, correct?
Okay, all right, guys, I was just like, okay, hold
Yep.
on. Math is not always my strong suit, but
Yeah, I can't afford, and I don't think I have the PTO for every week. I'd love
Yeah.
it,
no,
but
Yeah.
right, right. And then I think I echo sort of Don's concern of, given that we're already 6 years into basically a program that times out in, another year or so. I honestly don't know that you have 6 months to do this whole cycles a bunch of times. So I'll be
right.
interested to hear what Melody and Ruth have to say about that. I'm just not sure. I mean, I think that you'll want to personally continue on to do that. It will make a much
Oh, sure.
better study, as you said. I think we can all agree on that. I'm just not sure from a student perspective that at this point makes any sense at all. I think you'll be lucky to do one 4 month cycle.
Yeah.
And as Don was kind of mentioning, obviously having your providers continuing on months 2, 3, and 4, and you doing check-ins with them throughout that time.
Mhm.
But I don't think that it can be a month 1 we do this, and month 2 we do
Right.
this, and month 3. I think we're gonna have to speed that up for this to ever come to a conclusion, just to help you out with that. I think you're
Right.
on the right track as far as, like, I certainly hope you would continue it
Oh,
beyond
yeah.
this, and you can write that into the paper that, that this is going to continue on. But I think just from a practicality standpoint, I don't know that you're going to have
Yeah.
all that
Yeah,
data
you
to
could do
represent to us.
multiple rapid cycles.
Right. That's
One
where
cycle, yeah. Mhm.
that's kind of where that's where it feels jumbled a little bit in my planning.
Well, I'm going to jump in right there and just say your project proposal needs to be really specific about what you're going to do and when you're going to do it, and not say, I'm going to be reevaluating. I mean, to Jules's point, this is a really short, we want we want this to be done.
Mhm.
We don't want this to be
Right.
a lifetime project. And so that was the thing that I was missing in your paper, were the specifics of, I felt like there was a little bit of wishy-washiness about, well, I might do this and I might do that. And they were all really good.
Right.
So, but so what, what my lead research team told me was, your proposal needs to give you your roadmap that you can go back, like you might get a month into this and you might say, oh, dang, what was I supposed to be doing next? So you need to be able to go back to your project and say, this is what I was supposed to be doing. And making sure it's sort of your quality control also to make sure that you are sticking with it. So that was one of the things that I was looking. I might not have the right iteration of your paper, so you may have added that in there. I don't know if I have the right.
Yeah, I fixed some, but no, it needs to be clarified. I agree. I agree. That will help me too. So
Yeah, I think you mentioned a 3-month. I'm trying to find it.
yeah, it's
Following orientation, providers integrate routine practice for a 3-month period, specifically during visits women age 40 to 60. But
right.
yeah, but saying then that you will do multiple check-ins.
Yeah, I mean, it
might-
needs to be more weekly.
It might help even to have like a 1, 2, 3 steps,
Yeah.
1, 2, 3, and then you
Mhm.
elaborate on that. It would give yourself kind of a summary and yeah, a little bit, and then, but then you don't keep it at that 1, 2, 3, 4. You elaborate so that you
Mhm.
know what you're going to be doing in step 1 or whatever.
Mhm.
I don't know.
I think, again, what I'm hearing with Ruth and what I'm completely in agreement with is, like, I heard you say month 1, I'm going to plan, I'm going to get my IRB, I'm going to, start to come up with the toolkit and all of that. And, like, quite honestly, those things need to be done before you start. like, we need to approve the toolkit that you're going to do. We need to approve the pre-survey that you're going to do.
Well,
Or
oh,
are those, can those be part of implementation? Like, who's
well,
going to
I
approve
was
those
I
documents?
was thinking that developing it was part of the project is how I saw it.
Okay,
That's
okay,
what I,
that's,
yeah,
okay,
yeah. So I'm not implementing in month one. I'm developing
That's how I saw
everything.
it anyway. But if you disagree with me, Jewel, I saw the development as part of what she was doing for the project.
okay,
Like
okay.
the creation of the
Yeah.
toolkit and then being able to
So it's
have
going to be
people use it.
you and her site mentor and stuff that are going to serve as like, okay, she's 1 month
check.
in. Let's say we're now at October, and
Yeah.
Catherine's coming back to you, your team, and she's saying, okay, here's the toolkit materials. Let's get a stamp of approval, and then I'm going to start to implement them next month.
Yeah.
I see it that way.
Okay,
Again, if you
that's what
think
I need to
otherwise,
see. And I think that's what Ruth is saying she needs to see.
Yeah.
I want to see by October
Yeah.
1st, I'm going to
Yeah.
have a toolkit. It's going to be approved by my team. By October 1st, I'm going to have the pre-survey shown to my team. Like, we don't have to vet that
Got
if that's going to be
Mhm.
part of the project. I'm fine with that, but I
Yeah.
want to see the timeline of when those deliverables are going to happen, and that there is a group of peers, of people that are going to be giving her
Involved.
a stamp of approval, that this is not just Catherine
Right.
Yeah, I guess that's
pre-dating
the
and ruling.
sentence
There
that's
has
supposed
to be a vetting process to her materials.
That was one of my big questions is, how are you gonna decide what's in your toolkit?
I know that. Yeah.
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 And who's gonna validate? And that was one of my
Well-
questions about even the questionnaire that you sent out, the pre-survey. How did you decide what your questions were? How, was that just a Catherine committee of Catherine, or was that vetted? Because one of the things that I kept coming back to in your paper was, okay, so Catherine has some great ideas here, but how does she know that this is legitimate, that this is valid, that these questions are really getting at what she wants to ask?
Yeah.
Those kind of questions.
Yeah. It was my needs assessment. So I guess, yeah,
Yeah.
I mean, I use that based on my years of experience. So I guess, right. And
So you
all
just
of the
say
school.
that. So you
Okay.
say that in your paper, the questions came out of X number of years in clinical practice and knowing, and I mean, because you're an expert.
I think I did
Well,
write that,
maybe,
but
I don't
that,
know, Jewel
yeah.
and Melody, is that right?
Yeah,
Oh.
I mean, yeah, I think, to me, the needs, and yes, I agree. I think that would be a good statement to add in. To me,
Yeah.
the needs assessment was, background information to validate, well, the need, right? And so
Yeah.
it wasn't a formal part of the project. It was,
Right.
but saying what your expertise is certainly lends more credibility to the kind of questions that you ask. And you did change, I gave you some feedback on what you were
Yeah.
going to do as your pre-post survey, and I said you added in then that you need that to be validated by experts, and you're going to use faculty
Yes. I did.
experts for that.
Yep.
So that, I think you did add that in. And
In the paper.
I don't remember, Ruth, if that's the one that I forwarded to you or not, but she did make that change.
Yeah.
Okay.
Yeah, that was in the final paper. I haven't made any changes since that final one. And I did definitely add, it is in there. As far as it was 2 experts.
Mhm.
What was Laura? No, who was the name, Melody?
But yeah, I said that there were a couple of us that use the theory of plan, or
Yes.
and then that had something similar. So Laura and I could, potentially
Yeah.
Ruth, all
Yep.
did more things that involved qualitative or
Yeah.
theory. I
Yeah.
think Ruth, did you? I know Laura and I did anyway. So
Yeah, Ruth does. I found then later on the resource on the DNP that Ruth does qualitative consulting, and then it was Melody and I don't know what her name is. It's somebody from
Laura Yoder. Laura
Yoder.
Yoder.
Yeah, I don't know who that is. But I did put in the paper that I would be consulting with experts on that.
Yeah.
Oh, that wasn't in the version that I
The
read.
one, so Ruth, that's my fault. I didn't send you the right one. I gave her a bunch of feedback and she
Yeah.
fixed a bunch of things. So
Well,
I apologize.
in fairness, it should have been Catherine that sent me the paper. So
Well, I think we're just
just getting
Okay.
it done.
A little mixed up here, so.
Sorry, I'll send the
Thank-
right one. I didn't,
Okay,
yeah.
yeah,
Yeah, because she actually then changed, we discussed like, she wouldn't have enough data to really do a thematic analysis, and so they
okay,
changed that wording. There's one place, Catherine, that you still use it,
Yep,
and the one I sent back to you, but
Yep.
in your final, where you discuss it, you just talk about looking for, I forget what the wording is, but you
Yeah.
say you can't really do themes, but you can use the information. I forget how you worded it, but
yeah.
a formal thematic analysis will not be conducted, will be reviewed descriptively to identify illustrative responses. Yeah, related to it.
that sounds good.
Yeah. Yeah, that's, yeah.
Well, yeah, that's my fault for not sending it. I didn't
Well,
realize that.
And I apologize, Catherine, that I did,
It is what it is. It's fine.
but
just-
yeah, so,
Knowing that it's there, that's good.
yeah, there were,
The
there were
final
a number
paper.
of things, Catherine, that you changed based on
Oh, yeah.
feedback.
Yeah,
So-
the final paper is much better, Ruth. Like if you haven't seen that one, there's so many changes that I did.
Yeah, you added the balancing factor.
Yeah,
Yeah, there were a number of things.
there were lots. Yeah.
Well, I wondered about a little bit more content on theory.
Yeah, I
Uh,
have, oh,
You did that
because-
too, I think.
Okay, because the paper that I read, even the very first mention of the TB, the theory of planned behavior, it starts out with an acronym and there's no, it just jumps right in. So maybe, yeah.
Mhm.
I thought that the conceptual framework I thought was pretty well done. And I just have to say that you did I really, really appreciated how you made an explanation in your presentation that you said this theory, when you were talking about the theory, you said that theory is for the providers.
Mhm.
I thought that was,
Mhm.
oh man, I'd love to see that in your paper because I think that that's one of those disconnects that happens between theory and practice. And so, you know, students will sometimes talk about theory, but then they forget to say, well, so how does that connect to practice? And I thought just that statement was great.
yeah.
Yeah.
Well, and if I can piggyback on that, Ruth, not only was that statement great, but even your needs assessment, I think, Catherine, speaks so strongly to that. For you to say that 85% of these, again,
Yes.
13 out of 30 people is honestly a fairly decent response rate.
Oh, it
Yeah.
is. Yeah.
I was surprised.
For 85 of them to be like, yes, and we want more
Mhm.
education, like it ties to your theory of like
Mhm.
they are sort of
Mhm.
primed for this behavioral change. And that's, I mean, your three things are I want to improve their confidence, their knowledge, and their treatment plans. And it's like they're saying, yes, we want that.
Yeah.
Yes.
Yeah,
So-
I have I have a whole section in the paper, in the newest paper, there's an actual subsection that says
Yeah.
application of TPP to
is.
provider behavior.
Oh.
Yeah,
That's
and then,
awesome.
there's like
Maybe I
a
do
career-
want to
paragraphs
see
there.
your
Yeah.
paper.
Yeah, yeah, that's again.
Oh my
sorry.
God.
Don't worry, Melody, no worries.
But
Don't
at least we're
Yeah.
thinking alike. Like I gave some feedback and that was
Yeah.
the same feedback
Yeah,
that
that's
so we're
awesome.
consistent.
Yeah, we in the beginning, Melody was like, how can this be used on this? And I was
Because
like,
I'm used to it being used with patients.
right.
so,
And
yeah.
I was like, no. This is
It's just-
changing and behaviors of the provider. It's so
Mhm.
important because
Yeah.
yeah.
Yeah, I actually found some literature that where other folks have used it applied to
Yeah.
providers. And I was like, yeah, okay, well, you go for it.
I think on this vein, I think your PICO question is incorrect.
Oh no. Okay.
Because and the reason I say that is because your intervention was all about patient education, and that is not your intervention. Your
No.
intervention is really what you were listing as your outcome. That your outcome was that your providers are going to, and this is just from her slide that she was sharing today, you guys. I think that her intervention and her outcomes are switched because I think she's identified her population. Like if the education is geared towards the physicians, they're the ones that are making the change. They're getting more knowledge. They're putting resources in their patient's hand. The patients are the ones that are on a technicality, I think that they're the ones that are the outcome of, or the outcomes, the confidence, or I'm not sure.
Yeah, that's
help
what I was,
me, help me out, you guys. But I don't know that that the patients have any part of this. I mean, they're going to benefit, but if the whole thing is geared towards our providers' confidence, knowledge, and lack of resources, I don't know that the patients play a part in it. And I'd almost have to see that slide again. I should have taken
Well, her
But, you know,
comparison is affects
my,
provider recognition of menopause symptoms, knowledge, and confidence in
because
management.
I originally was going to do both, and I thought,
Uh,
I mean, I originally, and this PICO question changed a lot, and I was going to do, let's try to do both, and I thought, that's crazy. So,
no.
but
And I
but the,
like where you're going, Catherine.
yeah,
I absolutely believe the providers are your target group.
yep,
Now, obviously, the population of menopausal women, and I myself, thank you
yeah,
greatly. Got my patches, my creams, my
yeah.
progesterone, all the things. Um,
so you're
yeah,
saying, Jewel, that population even is wrong?
it
Because
might be.
it isn't,
Oh,
it
I'd have
isn't
to look
women,
at it.
oh,
it isn't women ages 40 to
no,
60.
oh, I
It's
see what I see
providers.
that beginning. Oh,
It's the
it's the
PCPs that are
PCP. Yeah,
providing
yeah,
Then
care.
that I understand, because this is where she conceptually thought
Yeah,
started. Like, I want to
yeah,
help
yeah,
these
yeah,
people, and
yeah,
they are the
yeah,
end
yeah.
population. But as this
Mhm.
has morphed,
yeah,
It's about the
they're really not
providers.
who the PICO question is. I mean,
No,
the
you're right.
project has turned to,
Mhm.
yeah,
so I'm like, it all ties together, and it's sort of a small thing, but I'm like, as
no,
your
that's
thing developed, I'm like,
Yeah,
that actually just needs a little tweaking.
yeah.
yeah,
Um,
yeah. No,
and I
that's
love it, because at the end of the day, all of this is benefiting all those
patient,
menopausal women, but they're not
yeah.
your target anymore.
right,
I
Right, right,
mean,
right.
they are,
Yeah.
but it's in an inadvertent sort of
Well, and
thing.
you're not measuring anything about them. You're only
Yeah,
measuring the providers. And while you are creating some patient ed materials, that's not, yeah, that's like a
yeah,
little bonus.
right, right. Um, I also thought too, like, it felt shocking to me that this group of people that are still providing care, and I get that women are like a subset of, all the care that they provide, but for them not to have realized the errors, like, this feels pretty like mainstream to me anymore, that people would understand like the errors that took place in that. And so that I felt was a little bit concerning too, of like, that really does again tie back to that theory. Like, they didn't even understand the knowledge gap that they had.
Mhm.
yeah.
Uh,
When I started this, Dr. Berger, I talked to him about it, and he was like, I knew when that data came out, we all knew, and we would talk about it, that how did they get this from that? And it all had to do with the media.
yeah.
Crazy.
And that's, you've got a real gift there that you have providers that were around when all of that originated. And so that, again, that historical context is so good to include in your paper, because it
It did.
Yeah.
helps us understand why we are where we are and what interventions are needed in order to get into evidence-based
Yeah. It's
practice.
mind blowing. I
Yeah,
cannot believe this happened. I mean,
yeah.
It does speak to like the reticence that we're seeing of providers not wanting to prescribe this, because they feel like they were sort of publicly shamed of like, okay, we were doing this thing and it caused harm. Like, of course they're hesitant to be like, oh, let's go back and do this. But um, yeah, I just, it all makes sense. And it was a lovely,
yeah. Well,
yeah,
remember
really
learning
a
in
good
school?
presentation.
Do you remember learning in school that it takes 15 years for anything
Yeah.
new? So we're at 16 of just not having it. So, I mean, I can only make a little difference, but this will take a long time because we only go to one education seminar a year. We half listen to it because we're exhausted. We may take some of it in, and in that presentation, we have to listen to not just, it might have a women's health speaker, but right now it's more focused on GI and liver and fatty liver, and like menopause is not right now in the top of our conferences, and we have to choose, do I go to derm, do I go to a primary care, do I do a
Mm,
farm update, do I go to, so we may
yeah,
or may not get it. And so
Yeah.
yeah, it's just
yeah.
crazy.
No, I think this was really important.
Yeah,
That's is incredibly important and can go beyond your practice.
yeah.
I have a question about your toolkit.
Yes.
So is the toolkit something that you are developing, or you mentioned that there are 2 existing toolkits? And so if you're developing a toolkit, what's wrong with the 2 existing toolkits? Or
Nothing's
do I
wrong
have
with
that
them.
wrong?
No,
No,
I mean,
that's my question too.
it's one of
Oh.
my thoughts. The toolkits are, so the India one is this thick. Like it's so much info. And then so the one that we are using in my office is from Australia, and it's great, but there are probably 10 different types of estrogen listed on it. So I'm trying to figure out, this is kind of where I'm stumped, and where I'm going to definitely have to use lots and lots of resource people, and because I don't really want to add those in, but you have to. If because I don't even entertain drug reps for a reason. I don't do lunches in my office for a reason with drug reps, because their product may be one product, but that doesn't mean it's the best. So what is the data? And I don't, this is where it's like it's big. So I want my toolkit to be simple, but I risk narrowing and myself being a drug rep, So yes, I have the toolkit, and I definitely am going to incorporate a lot of it. I mean, I haven't had time, to be honest, because this has been my focus of just getting the paper all together. So I can't wait to get into the bones of this. But I haven't had a lot of time. So yes, I have 2, and I really want to take some from one. And other countries do use different things, right? And I never use conjugated estrogen, but I think that they still do in gynecology. So do I add it? I should add it. So that's where I'm at. I don't know.
Yeah.
One of the things that I said to, sorry, to Melody as you were doing this is I do wonder, like, have you been in consultation with Goshen Women's Health?
Yeah, well,
Like,
I mean, I have full access to them. There's 2 providers and I should have included this in the presentation. I am going to get menopause certified. I haven't
okay.
yet, but that's my plan. And then I have 2 NP colleagues that I have direct access to that are menopause certified. So
Okay.
absolutely, because I'm a primary care provider, right? It seems
Right,
weird,
right.
but it's just so important. So I am going to that's my plan. I got to figure it out, but that will
Not
be,
now,
well,
not till you're done.
no, right? But
Don't get menopause certified now.
right.
That's a future thing.
And
Good
I
job,
wish I
Ruth.
could do it now.
Yeah.
There's a textbook that I'm ordering from the Menopause Society that is all things, everything you need. It's this thick too. So that I will use also for the toolkit. So it's going to be a lot, and sorting through what is the best and easiest for primary care. I think that's also the key. We are
Yeah.
not gynecology, right? We're primary care.
And that's why
Yeah.
I'm like, if your book says there's these 10 different like estrogen iteratives, like that's fine. But if I'm your patient, I want to know what's affordable. Like, so take those
Yes.
10 and do the deep dive. What's affordable? What's available? How, what's the ease of use? And then, you and your peer colleagues could decide, this is great that they have 10, we have 5 that we're able to get
Right.
easy access to. Like
Yep.
in my toolbook, I'm going to say there are these 10 here locally, these 5 are available. Like, so I
That's
do
it.
think you can take the toolbook, go through it, and then make it simple, because I do want my provider to be knowledgeable and give me a couple of options, but
Yes.
Yeah.
And that's
Yeah.
what we're actually doing. So at least I
Yeah.
have that. I mean, I can tell you right now where to get the cream, where to get the patches cheapest, which website, which are,
Yeah.
so at least I already know that I can do that. I've already done it for other providers. So yes, you're
Yeah,
right.
I see that as like part of the algorithm. So you have
Yes.
an algorithm,
ding,
Yes.
ding.
you have these things. Now, if
Right.
someone wants a deeper dive, then you have these toolkits that go, maybe
Yes.
that's like a reference, like, oh, this patient might need this. I need to dive
Yeah.
deeper. But
Yeah.
So she's
here's
not
what I've
making a tool.
synthesized.
Yeah, she's not making the toolkit. She's synthesizing and pulling
Yeah.
out the particular things
Yes.
and embedding them in the algorithm and crediting in your algorithm.
Yeah.
I
Yes.
got it from this or whatever.
Yes,
I'm-
that's exactly it.
I'm conceptualizing the way you're using toolkit actually as the toolkit is what I'm seeing, the symptom
Algorithm.
checklist, the treatment algorithm, the patient education, the access. To me,
I
that's
think
how
we should call it a bundle or something, not a
I know.
toolkit then. Like,
well, it's
I wonder. I don't know. I don't know
yeah,
that it needs to,
Yeah.
MHT treatment bundle,
yeah, something like that, or
practice bundle for him. Yeah. Yeah,
Well,
maybe it's the
well,
terminology.
I'm still thinking that it's okay to call it a toolkit.
Do you? Okay.
maybe is. I mean,
Just
Yeah.
because
It is a
it's,
toolkit, I guess. Yeah.
yeah, because it's something, it's a standalone item and it provides, I love the idea that it's gonna be, I mean, that you perceive it as, foresee it to be an online tool and you'll have hyperlinks, embedded in that.
Mhm.
And it could go to other resources, including the two existing toolkits. But what I'm hearing you say is that this toolkit is going to be more condensed, more
Yep.
applicable to your patient population in northern Indiana, well, maybe the US.
Right.
Rather than because these
Worldwide.
toolkits are from international
Yep.
resources.
Yeah.
So this might be the first toolkit that's available for you at the US population.
Mhm.
So I don't have a problem with
Okay.
the
Yeah.
language.
Then, yeah, then I'm good.
Yeah.
I had one question, or can we?
well, keep going.
I have one question about you're saying the training is optional. I know you can't force people, but it feels like kind of an essential part of what you're trying to do is to provide education to the providers so that they can. So I'm not quite sure what to do with the optional piece of that.
I think that I need to reword it because what I find all the time is if you tell someone you need to sit with me for 15 to 20 minutes, I know myself, I won't do it. I don't have that time. And so I need to reword it as, and I kind of put that in there as it being a modular. And so it's either, I would like I want it, I think it might be in the paper, but via Zoom. And if you don't attend, then you have this that,
Okay.
here's your
Yeah. Okay.
module.
Yeah.
That's the attendance of the 15
The-
face-to-face
That's
is
optional.
optional.
Okay,
But
that's fine.
the training module, right? Yeah,
And it
it's a
might be
toolkit.
just how you said it versus
Yeah,
what.
you're right. But yeah, no, because it is almost impossible.
Yeah. Yeah.
Yeah. So if I say to someone, hey, I've already asked, I really wanted Ann Love to do this and she wasn't interested because we're all just she's a nurse practitioner in our network. She went to Goshen, right, Ruth? Ann Love? Oh, okay.
Not for her FNP.
Okay. She was like,
She got her
but I'll
FNP.
watch.
She got her FNP before our program.
Okay. But I was bummed. So I have to be like, okay, well, hey, will you do this? You don't have to do anything other than do you want some access? Would you like something to hold on to quick? I'd love to teach you about hormone therapy. And that's it.
Do you have a way of oh, go ahead, Ruth.
Does the health system require so many kinds of I don't know,
Continuing
like,
Health
education.
could they get any kind of points for participating in your okay.
No, but so we do this thing called it's ACO. So and
Mhm.
the ACO is like where the insurance kind of
Yeah.
goes through sort of. So the ACO, we have a meeting every month, and our ACO is not just Goshen Health, it's also like where Dina works and a couple different ones. Okay, so they are there was one of the nurses that I take care of knows that I'm doing this. She told them, hey, Catherine's doing this in primary care. So there's talk about me giving a presentation along with gynecology coming up because every month we bring in a specialty and we all have to listen. We all hate it, but we get like lunch paid for and we go because we get whatever. And so like some of the providers go to that. They don't get points per se, but it's really recommended. And
Yeah.
so it might be, but everybody's interested. And like I said,
Mhm.
like knowing the more and more and more we go, hey, you know, like MHT, you know, it's not as bad as we think. We can do it now. It's the only really great treatment. So that it would be great for me to do that, but it makes me so nervous because I feel like I fall apart when it comes to these good old boy doctors that I'm just like, oh, you know, like I don't know if I could do it. So maybe I can collaborate with gynecology and I can just make sure they maybe implement my plan. Anyway, either way, it hopefully will be talked about then, but it's everybody just kind of like has this every meeting, like
Mhm.
there's no questions, there's no this, and it's every single month of different stuff. It's just everybody's overworked. So, but those that are passionate about it, I've already talked to a lot, and I've been getting like questions from all kinds of primary care. Hey, I heard you're doing this. Like, do you have any resources for me?
Right. Okay.
And the girls in
Got
my
some
office,
buy-in.
yeah, it's great. I wish I had more room on my schedule, but I don't. So like, um, so we have to just keep moving it on. So it's going to be very effective. But what was the original question? I'm so sorry.
It's
Oh,
the
you
training
answered.
No, that's
optional.
good. Yeah.
Okay.
Yeah. Well, about
Yeah.
training.
Yeah.
Yeah.
All right, Ruth,
So,
Melody, are you ready for us to convene?
Mm-hmm.
so I
Okay.
want to review just, oh, so what I heard
Well,
was,
we're
Oh.
going to go talk. We
okay,
will come back
back.
and we're going to give you sort of some formalized feedback. So we
Yep.
will give you some bullet points on what needs to change.
Yep.
You are going to get this video that you can hear that again as well. So yes, we will make sure you leave here today knowing
The plan.
where you stand and what the plan is, okay?
Okay, perfect.
Okay, so you're
Do
gonna
I-
sit tight here and
Okay.
we're gonna go in a breakout room. Create one breakout room, assign manually.
Oh, and stop recording.
Oh yeah.
All right. Congratulations, Catherine. Your proposal is approved.
Dreamers.
Oh my gosh, I'm so excited.
Yes. You should be proud of yourself.
Thank you.
Have a great, much needed project. You're clear evidence that this is a problem that needs to be addressed. Excellent history and review of the literature. You've got a good solid plan. We have a few things we'd like you to add before moving forward, and we want you to fix this in the next week
Okay.
so that you can go ahead and move forward.
Yep.
And actually, Jewel, I'll let you. I think you did a better job writing the things down probably than I did. If you want to, I can start if you want, but
I think our main thing, Catherine, is just make it explicit to us of what steps you're going to take. And I
Yeah.
said, you know, I think you're almost afraid to commit. And I'm like, it's fine, commit. Give us a timeline of, you know, again, I've been throwing out October 1st, whatever that first due date is. I'm going to do X, Y, and Z by November 1st, by December 1st. Just spell them out so that we know. And again, I said to Ruth and Melody, this is not set in stone. That's why you've got your team. That's why you've got Melody. That's why you've got your
Okay.
project. Like, again, you come to them and you're saying, hey, ladies, this took a turn, it took a divergence. Like,
Okay.
they're your group to help you. But again, I think that's going to help
Yeah.
you. You've made such good strides, whether it's your new spouse, whatever is going on. We love it for you. But we're like, let's give you a timeline that really kind of, again, keeps you going, keeps this motivation and momentum that you've got going here because it's a great project. You've got great plans, and we just all want to see you kind of get to fruition. So that's your main thing of like, just give us a timeline, think
Okay.
through all
Yeah.
those steps that you wanted to do, and like just plug them in. Where do they make sense in this, you know, 3 to 4 month timeline? I think that's our main thing. We would like to see a little bit more on sort of the theory that you're using. I'm the least familiar with it, so I'm getting the education with it, and I just need I think we all were kind of saying just a little bit more information on the theory. How does this completely apply to your project? I mean, we looked at your paper in our breakout room and stuff, and so you've done
Yeah, the newest
quite a
paper?
bit on that. Yes,
Okay.
Melody pulled up the
Okay.
newest one.
Okay.
So give us just,
Like more
Okay.
about the theory. What is the
Yeah.
theory? What are the elements of the theory? Explain them a
Yep.
little bit more. What is
Okay.
the perceived control? What does that mean? What are all those pieces? You
Okay. Yep.
get a little bit more application to your project in a separate section. And yet, like, it's kind of like, okay, but what is this theory actually say?
Okay.
So, that could easily be
Yeah.
a page and a half or 2 pages or something like
Okay.
explaining that theory. Yeah.
Okay.
again, your concept was really, really well done. We felt like that part was great. That you don't need to mess with that. Just explain the theory for somebody like me that does not know what this theory is. Like, help me
Okay.
understand what the theory is. You talk
Yeah.
about how you're applying it, but if I don't know the theory to start off with, like that's
Mhm.
this
Yeah.
is just a small thing, but like on your paper, I think it said that it was like submitted to Ruth, and probably back in the day it probably was. But let's just change that to Melody's name now.
Oh,
Um,
okay.
just that she's the person that's kind of grading it at this point.
Okay.
And then our other note for you, and again, you're not going to do anything with this right in this moment, but when you come back to do your final presentation, make sure that you're using APA in your slides as you're citing, like, the history. You'll want to have a few little, here's where we got this information. And at the end, we're going to want a reference page. Your final
Okay.
slide, you can have a thank you, and then you're going to flip to references. And those are the
Yeah.
references you used in your presentation. If you want to, at the end, say something like, if you want to see the full list of references, you can ask for my paper, because your paper will have more than probably what you use in the slides.
Yeah.
But
But still have, okay.
yeah, give us a
Yeah.
reference list of what your references are for the slides.
Okay. I thought about that.
Once you are about a week out from here and you get those, these few updates into us, Melody will grade your paper.
Okay.
I'm gonna,
Actually,
oh, go
I
ahead.
grade the one, don't I grade the one that she submitted
Yeah,
now?
I will
Yeah.
just, I need a
Oh,
grade
you
for
mean
the
like a
paper.
value?
Yeah.
Okay, sorry. Okay,
Give me
yeah.
a grade. I'm
Okay,
gonna throw that into the old grade book, and I will get a grade submitted, and you will be through 800 and on to 804.
Okay.
As a
802.
house, 802,
802.
802.
Yeah.
Yeah. Um, I, as a sort of housekeeping item, Catherine, we are switching Moodle sites.
Yeah.
I don't know
Okay.
if you've seen all of that. So I just the other day had an 802 built for you. So I need to clean it up a little bit. I really just want it to kind of get to like the absolute things that I want you to be doing in that. But so I may send you an email of, hey, Catherine, now that you're in 802, and I'll just spell out some of the things that you need to do. 802 really is for you to be working on your project. So there is not a lot of extra coursework. It's a
Right.
pass, no pass class. So again, I just say that just that that's a housekeeping item that we need to, on your transcript, get you through that class. But it's doing your project work,
Right.
basically. And then the last thing, again, is just that at this point on your signature line, that sort of thing, you can start referring to yourself as DNPC, that you are a
Oh.
candidate, a doctoral candidate.
Okay.
So,
DNP-C.
yeah,
NP-C. And and that's on my papers and stuff, you mean?
yeah, your
Okay.
papers, your professional life, like that is the point you are
Oh,
at.
really?
So, yeah,
Mhm.
Yep.
Wow.
I know.
Okay.
You own that now.
That's
Yep.
exciting.
It is. That's awesome.
Okay. So I have a couple questions
Yeah.
about this stuff. Okay. So
Yep.
for the 802, so I was in this has to do with like credits because I'm paying like boku amount on my loans. So can I defer yet, do you think? I don't know how many credits I'm technically enrolled.
You're enrolled in one credit.
Oh, just
You
one.
are in one credit because that is your continuation. So you have technically, Catherine, paid for the
Right.
entirety of the program.
Right.
Uh-huh.
That's what I
But
thought.
because you have not completed the program, every semester you pay for one credit that basically keeps you in our system and keeps us working with
Okay.
you to get through.
Right.
So you're paying one credit a semester. Yeah, that's the
Yep.
answer. You're paying one
Okay.
credit a semester
Okay,
until you
so
finish.
so even though I'm enrolled technically in 802, which is what? Is it 3 or 6?
6.
6. You're
6.
not getting charged 6. You've already paid the 6.
But I'm
You're,
doing the work. I'd love to defer my loans if that. Do you know if I can do that? Maybe
I
I
don't
just
think so. Not
I
while
don't
you're
think I can.
still in continuation status.
Okay.
I don't know that. I mean, I don't know that for sure
Right.
unless you want to pay this out of pocket, your
I
continuation status.
pay every month out of pocket or every
So I
quarter.
don't know. Maybe you can,
So
but you're still in
Financial aid,
school. I don't know.
would financial aid office be able to
Yeah.
answer that question? I think
Yeah.
that
Okay.
might be a financial aid question.
Yeah.
Okay. And then okay, so the 802
But they don't experience this very often, and so
I
you have
know.
to make sure that they totally understand that you've done, that you are in a continuation
Yeah.
Yeah.
mode.
Yeah.
And then so switching Moodle, you built it to pass, no pass. Oh, so one of the reasons the timeline was not the way I really wanted it is like I really wanted to put it, but I was so confused on, and I wanted to get it done. So I didn't ask the details to Melody because it's just time. So how do you put that in the paper for APA? There's not a lot of like good data on, what I really want to do is make a timeline. Should I do an appendix like that? Because
You
I
can
put it
just
all
make
in
a
the paragraph.
narrative, or
Or a
you can
table
draw it, or
or
you could
Like a
make a
table. Yeah.
timeline, or you can do a narrative.
So
What do you say?
what I suggested, Catherine, in your paper is that you say, have a section that this
Yeah.
is the plan. And I mean, it's probably a subsection, and that you have an introductory paragraph, and then you do a
Hmm.
October 1 X,
Yeah.
2.2, and then you go through and elaborate on what is going to actually happen on
Okay.
October 2.
Mm-hmm.
And the timeline doesn't have to be like a literal timeline.
No.
It can be a point by point kind
Yeah,
of a
bulleted
thing.
list, or
Yeah.
Yeah.
That's
1, 2,
Bullet
3,
point.
4.
okay. That's what because I need to see the bullets. Everything else just turns
Mhm.
into a paragraph of
Mhm.
words.
Yep.
Okay, so that's appropriate. That's what I wasn't
Mhm.
sure.
Yep.
Okay, and then should I change my PICO?
Yeah. I just
Yes.
added that
Yes.
on
Yeah,
my
okay.
list.
Yeah.
Yep. Change your PICO.
Population, providers.
Mhm.
And did you see, I think Melody in the chat put
Oh.
in sort of
Yeah,
a,
my PICO.
Well,
Oh,
no,
okay.
that was what she had. I was
Yeah,
oh,
just,
that was what I
that's
had.
what she had. I was just
I
popping
was like,
in.
oh,
No,
Yeah.
no.
all right.
So it's population and okay, I'll look into that. And
Yeah.
then
Population, what are the interventions? And those are
Right.
all the things your providers are doing.
Right.
Which
Your
I think
control and your
there.
outcome and time.
Okay. What does that mean? Okay. Oh, so if I'm trying to, so I have one more class, right, that I have to actually attend, which is 804.
Correct.
So there
Yes.
is an 804 in spring,
Next summer.
summer. Okay. So I could potentially, I see it as implementing like literally starting now and then, or next month, whatever. And then October, November, December, January, February, March. So that brings me to like March and April for being at least implementation done. So will I potentially be able to graduate in May and finish the 804? What do you think? How does this work?
Well, I'm thinking October, November, December, January.
Okay.
By January, I would like you into 804.
Oh, I can do that if there's not an 804 going on.
There's
Did
not an
she
802
already?
going on right now either.
Oh,
You're
yeah.
in independent studies. We have created these
Okay.
classes as a holding place for you to submit your
Right.
work.
Right. I just
So-
never attended because I was technically in 802 once, but
Mhm.
didn't get.
But you've never enrolled in 804?
No. That's where I'm confused. Like, is that going to be okay? I mean, I'm okay with that. I'm totally okay with that. So could I potentially finish my 804 and graduate in, May? That's what I would like to do. Is that possible?
I think
So,
we could do an independent study 804. Go ahead, Ruth.
well, that's what I was gonna say. I'm just gonna say historically, what we did once before, or a couple of times maybe, is that developed, for example, with one person, we did a 700 as an independent study. And I think, I can't remember if we've done any of the 800 level courses as independent studies, but I kind of think we have. So I'm just throwing that
Yeah.
out there, that wouldn't be a new
I
precedent.
think that would be okay. We don't want to like do the whole sequence from the start to finish, but because you've been in already,
Yeah.
I would think we could do that. Now that one would be, you'd switch then from an 898 1 credit, and that is a 3 credit course then.
Okay. That makes sense.
Mhm.
So, because that one technically I don't think has been paid for because
Yeah.
I
Okay.
never was
Never
enrolled.
enrolled. Yeah.
Okay,
So
that's
would be
kind
the
of what I needed to know too.
Yeah.
Okay.
Good question. Good
Yeah.
question.
So I could potentially be done in May.
If you get it done,
Oh, that would be so great. Okay.
so you would
That's my
need
goal.
yep. So you want to so what you need to do, Catherine, just
Then I can't
sometime
do
with your
6
pencil down,
months.
is just back up your timeline.
Yep.
Start with what your goal is at
Yep.
the end, when you want to defend,
Yep.
what you have to have done before that. I need the paper 3 weeks before defense, a
Okay.
final paper. So like if you want some feedback, you're going to want to give me some drafts of the final paper.
Okay.
So just back your timeline up on your own and make yourself a self timeline, and then
Okay.
set that goal.
Perfect. All righty.
That would be awesome.
Yeah.
You will want to back up from about the date of about April 20th or so, Catherine. So plan to have your final paper in whatever 3 weeks from April 20. I mean, that's pretty much
Ish,
April
yeah,
1st.
April 1st.
End of March, early April. If you
Yeah.
can get your final paper
Okay.
in, your hours completed.
And that would be 100 and
120.
I forget.
Well,
120.
120.
120 for 804, 300 for me.
Right.
And I need to check to see. I mean, I haven't looked at our time.
I got to
Hours
finalize all that. I need to get on there and when I created my PowerPoint work, that's not part of the 120, is it? For this 800?
Did we ever? Oh, you
It
guys,
says
it's
in the
been so long.
handbook.
Okay, I'll look. I know I knew the writing of the paper wasn't. I'll look again because there's.
I think we allow a little bit, like I think we say you can, but not like, it's not like 20 hours worth or
Yeah.
anything. I
We
think
got
it's,
more specific, I think in the handbook.
Okay, I'll
yeah,
look.
Okay.
double check
In the
I'm like,
that.
we
handbook.
went round and round about
I
this,
know
you
we
guys,
did,
but I'm
yeah.
like, oh
'Cause I
man.
think we had somebody like put a whole lot of hours, and I'm like,
Yeah.
Yeah, we're like,
I mean,
you can't put 20 hours of creating a PowerPoint.
I don't know. I spent like
Yeah.
16. I
Well,
mean,
but yeah.
I know
So
what you
while
mean.
you may have spent that, that's not. Yeah.
Okay. All right.
Yes.
I think that's all. And then if I have more, I know where to go.
Sounds
Thank you.
good. So again, what you're going to get from us here is you're going to get this as a recording. I will try and get that email to you yet today. I will put on that paper that I put the link to your video. I'll put these kind of 6 or 7 things. Again, the main thing is just those specific dates in your paper. Then
Yeah.
that and I think more on the theory. The
Okay.
rest, as far as name change, references, Pico, like those are more like PowerPoint things for down the road. Although I'm sure your Pico is probably in your paper too.
Yeah,
But-
it is. And
So, yeah.
I did have references on the bottom of the slides, but you're right. I didn't do the final.
Right.
Illegible, Catherine. You couldn't read them.
Okay.
Well, and also
Got
it was, yeah, you need to put them like up with the things.
Okay,
Where
I'll
your
look up with-
citation
I'll-
belongs.
Yeah.
Yeah, I'll look up APA. I
Yeah.
didn't realize. Yeah, that's my fault.
Yep.
Yep. Thank you for pointing that out. Okay. Thank you guys.
If you've seen any of my PowerPoints, Catherine, you can use those as templates.
Yep, I definitely have that saved and
Um,
looked at it many times. So I don't know why the way the brain works when you're in all of this. It's
Oh,
amazing
yeah.
how you don't realize, well, duh, like, okay. Thank you. Thank
All
you.
right. Congratulations
Jewel,
again.
you're muted. You've changed cameras and you're muted.
All right. Well, Catherine,
Thank
be in
you, ladies.
touch. I'll look for updates by next
Okay.
Friday. Okay.
All righty. Sounds
All right.
good.
Right.
Happy
Congrats.
holiday weekend.
Congrats.
Oh, yeah, that's right.
Thank you.
Bye-bye.
Bye.